Hello, everybody. I'm Ron Waxman. We are from Washington, D.C., CRT Online, the special series on COVID-19. And I have the pleasure to have two individuals who are really on the front line. You can guess they're from New York. I have Dr. Weisz and Sharma from Mount Sinai and Gira Weisz from Montefiore in
Hello, Ron.
the Bronx. Welcome. First of all, I'm glad to see that both of you in good health. That's not trivial in New York when you have such a penetration of the disease. I don't know, it's like a 2 for 1,000 or something like that. It's pretty amazing what's going on there. So
interventional cardiologists are very strong.
Yes. So why don't you tell me, how do you cope with that? This has been going now for at least 5 weeks in your city. Maybe we'll start with you, Samin. I mean, how do you handle the work in the cath lab? What's happening in your hospital? As much as you can share with us, please do.
Sure. Ron, thank you for putting this together. This is a new way of talking and giving our ideas and expressing our views. And clearly, as we know, since almost now we are on the 6th week of shutdown in terms of our elective cases. So only patients which are being done in the cath lab are those who are elective, semi-urgent, which having chest pain but don't want to go to the emergency room, or patient with a tower who are very high risk, which basically we defined as either mean gradient of more than 50, valve area less than 0.7, or EF of less than 30. So those, besides having the STEMI and non-STEMI, and maybe we'll have a discussion later, so that number has significantly gone down. But all those semi-elective or semi-urgent elective cases and stable tower but high risk are being done. So just to give the number, our lab used to do 75 cases a day. In last 6 weeks, we are done on average 7 or 8. So only 10% of the cases. And this actually have come handy for the hospital, which is the biggest priority for them is to take care of the COVID patients. All the ICUs are full. ICUs have double patients, so 10 beds, usually serving 16 or 18 patients with the 2 ventilators in a room. And most of the ICUs or even telemetry were converted into a mini ICUs or the COVID. But in last 1 week, knowing the numbers have gone down, our ICU has cleared up, one of the ICU, and 2 telemetry units have also become non-COVID, and they're in process of cleaning, so that maybe in next couple of weeks, when the business starts coming back, roll on to our some cases, less kind of, a little more elective, but not truly had to be the urgent, but which we have postponed in last 4 or 5 weeks, that try to identify and bring them back. I had to just say one very important point in there, talking to the patient. Patients do not want to come. And particularly, our governor has said May 15. So all patients, I mean, again, we'll get other opinion, but even today, we called at least 20 patients, and of them, 2 are still, of course, symptomatic, having symptoms, but only 2 are coming next Tuesday, and they want to sit tight till May 15th. So that will be our biggest, I would say, the trouble or biggest, the problem will be once we start getting business back, that how do we win the confidence of the patient? When we are calling them, we are saying very clear that you'll be tested for COVID, and all the staff who will take care of you are already being tested for COVID. So we are saying that upfront. Even then, big reluctance for the patients to come back for even the semi-urgent care. And while it's not that they're asymptomatic, they have symptoms, but they want to ride it through till May 15th.
So it's very interesting. Even in your institution, it's not the lack of beds or CCU beds, it's more the fear of the patient.
At present, that is the #1 factor, yes.
Do you do towers right now?
Yeah, we did actually same. Those, like one we are doing today, that patient's mean gradient is 82. Your patient was waiting, and we scheduled him for, I think, May 18th or so, but patient syncopized day before, was in local hospital, transferred, and got the tower this morning. And same way, the last Thursday, we did 2 towers. One had the ejection fraction of 25%, was admitted day before. Second one also passed out, and we transferred. So kind of maybe 1.5 towers per week compared to usual, used to be about 10 per week. as again, same number, that about 10 to 15% of usual volume.
Yeah, we consider TAVR still as an emergency because, you know, the mortality at 1 year, if you don't treat them, is so high. And you don't
Not
know
only that,
when...
I can tell you in last 1 month, we had 5 deaths of the tower waiting. 5. We counted one actually, when we figured out we wanted to bring this patient next Monday, called, patient gone. So 5 in our wait list of last 6 weeks wait list, 5 patients died while waiting for tower.
Okay, Giora, let's move to the Bronx. Tell us, you have a very dense population as well. I think the mortality rate overall in the Bronx is higher than in Manhattan. Is that correct?
You know, we have a very high risk population, high percentage of immigrants, very low socioeconomical status, very high rates of hypertension, obesity, diabetes, and of course, those are the risk factors that we see also for the COVID outcomes. Regarding what we do in the cath lab right now, it's a similar situation. So basically, we decided and we comply with the order of the governor not to do elective cases. We do only STEMIs and very hot ACS patients that have continuous chest pain, unrest, and cannot be managed medically. And I see the same problem that patients, sometimes acute patients, are afraid to come to the hospital. I just personally cut a couple of days ago a young guy that was sitting at home for a week with chest pain. He came in with an extensive anterior wall MI with EF of less than 20, was in cardiogenic shock and the largest thrombus I've ever seen. So this is a problem. If patients are afraid to come to the hospital, we need to find a way to encourage them that hospital, yes, it can be a risky place, but we can also provide a safe environment. And I agree with you, Samin, what you said, that we need to check the patient and we need to check ourselves to make sure that it's bilateral. It's a clean environment from both directions. And then we need to find a way to do it. And I don't want to go into what to test and how to test it. I think this is not our field, but we need to get to be provided with this situation. Specifically in our hospital, we converted our holding area, so the pre and post procedure, we converted into intensive care unit, and it has two intensive care units. One is a CCU, and this is for what we call clean patients, those that are COVID negative. And we have also a full respiratory intensive care in our holding area. Those are all COVID positive. Almost all of them are on ventilators. The full-blown, multi-organ failure that we see now with this disease. We are basically holding this unit. So the physicians are the interventional cardiologists from our group, the cath lab nurses, and the technicians. And I can tell you it's actually managed very well. Everybody stepped up to the occasion. And we just, this week, we extubated 3 patients. And this is nothing more rewarding than extubating those guys with COVID that they were on ventilator, multi-organ failure. And it makes me happy to see those patients now sitting next to the bed and getting better.
Do you have deployment of your staff into the regular units? I think you just described it, but I just want to get the clearance. As an interventional cardiologist, if you're not very busy, are you being asked to be deployed to take care of COVID patients right now?
Yeah, so we're doing this COVID ICU, and that we are taking care of those patients. And in addition, some of us rotate on some of the regular, let's call it, what used to be internal medicine, now it's COVID floor.
And same thing here. Actually, because there are additional units were made, Ron, if you remember that once you enter into our main building, the atrium, the beauty place, all has been converted into beds.
Wow.
Additional 100+ beds, all throughout in Annenberg, the main and the side, and the used right now 1/3 capacity. But many other units opened up and there were no doctors. So Department of Medicine asked us that create a team of many of the internal medicine and the cardiology. So they are round the clock, giving the coverage. So what we did is we did identified like batches of 10. So do 4 days, take 4 days off, and then 4 days. So luckily in the night time, we found the hospitalist. So nighttime was good. So these all all practicing cardiologists, including interventionists, all doing the COVID call since mid March.
And if you have seen patients who are coming with normal coronaries and ST elevation by EKG?
Yes, we just had one of them, similar case this morning. Patients come with, you see the EKG, you don't think about pericarditis, you see it like a regional. This guy was with inferior, clearly ST elevation, and was almost normal coronary. So no signs of rupture plaque or any flow issues, but with a very low EF. So probably it's a myocardial involvement of COVID with normal coronaries or nearly normal coronaries.
Yeah, we actually had done 3 so far in the COVID positive, the STEMIs, and all 3 had a significant, occlusion, thrombotic. Whether one case was 42-year-old, all vessels clear, whether that case was inside to thrombosis, but other has a CAD occluded, and the third patient has a ISR, thrombotic ISR. So all 3 of 3, we did not have anybody with the normal coronary so far, but only 3 n equal to 3 experience.
So how does it go? A patient come, do you do a COVID test, or you just take them to the lab and irrespective, you just protect yourself, protect the staff, no matter what's it doesn't matter whether he's a positive or negative in terms of the policy to take them to the cath lab?
Yeah, so actually, we kind of, which has been raised in our recent publication circulation. And so think about the thrombolytic. We are not given thrombolytic to anybody, but key is that if patient has a no exposure and does not have those symptoms and is a young person, let's say the patient may be PUI, but we'll take it to the cath lab in that STEMI situation. If patient is a known COVID or looks like has an exposure to COVID, that patient, if has a multiple comorbidities, we are managing them medically. And if not, the other person, maybe you can bring it to the cath lab, do an angiogram, if require hemodynamic support, do a balloon pump and so. But so far, we haven't had that situation yet. But 3 patients of the COVID positive, we actually waited in 2 of them for COVID result to come, which took 6 hours. I mean, it's not a right practice, but it's taken everything together. We did what best possible. The question is, should we be giving thrombolytic while waiting for the COVID result, knowing which can take up to 6 to 8 hours? I think that part of the discussion ongoing at present. And since our hospital was not geared, we didn't know how to give TPA or TNK. We actually don't have TNK yet. They're getting the TNK now, the TPA. But we had just put 2 days ago, our protocol last Friday, actually, the protocol that how we'll give TPA for these patients, which we think clearly as a COVID positive and not a young person, but clearly ST elevation, does not have comorbidities or extensive comorbidities. I think those patients maybe that we just do a medical therapy, management with appropriate medical therapy. But we are looking for appropriate patient for thrombolytic, but we are ready now to give a TPA at present. And they say we'll get a TNK in our pharmacy in next 48 hours.
I find giving thrombolytics a little problematic. We had a patient a couple of days ago that got to the ER to another hospital and had ST elevation, got TPA, and was transferred to our hospital. He was cut by one of my colleagues that found normal coronaries. This patient, after that, suffered from complication from TNK, major bleeding. And the clinical picture looks like more that this COVID was, if there was a COVID patient that was complicated also by PE, that might be the problem, but had major bleeding. So we have to remember that thrombosis is not an innocent treatment, and giving that blindly, I'm not sure that's always the right thing. I think it's need really to pick those patients that maybe will benefit from that and with low risk. we divided our cath lab into clean cath lab and COVID cath lab. So when a patient comes with symptoms, it's clearly to put the patient in the COVID, even if we don't have the results. So we consider this patient as we think positive. So we think that the patient will be positive. And if it's a clear patient, we still swab the patient. Now we have the test that we get the result in 1 hour. So by the end of the case, we get the result. And since there are so many asymptomatic COVID patients, we get sometimes a result of positive COVID, although the patient did not know that he is carrier of the disease. And it's a problem. So there's no 100% of clean patient, there's no 100% of confirmed patient, because even if the test is negative, we know that the rate of false negatives is so high. I told you about this patient that came with cardiogenic shocks. His lungs is patchy infiltrates, very similar to COVID patient. We swabbed the patient out 3 times and he's still negative. I still don't believe it. So it's hard. We need to exercise a lot of clinical common sense here and not just rely on tests.
Samin, question to you about anticoagulation of those patients. I mean, we heard about thromboembolic events and thrombotic events. I mean, should we treat those patients more aggressively with anticoagulants? I mean, even if usually we try to minimize it for bleeding, but I'm not talking about PPA, but let's say low molecular weight heparin, any of those to continue after the procedure, after you close the groin, you secure that the entry site is closed. Is there any problems right now that you see with those patients potentially for stent thrombosis or other thrombotic event that should merit anticoagulation?
Yeah, so actually very good point. So what we had done at Sinai, they published the, have widespread circulated the anticoagulation protocol. So the question comes is that if your COVID, we are talking about only COVID positive patients. So is that if they're not a high risk in terms of increased oxygen requirement, the CRP, D dimers, the values which we have like a number. If not that, then give 2.5 milligram of apixaban twice a day. So in those cases, we are giving whether ticagrelor or clopidogrel plus apixaban. If they have a high risk feature, so continue while in the hospital, heparin, and then discharge them on full dose anticoagulation for 2 weeks. So that is a protocol has been adopted at Sinai, and we, unless patient has a high bleeding risk, we are doing it. Actually, just to say, one patient even before didn't need a cath, but they did this protocol, and patient has a brain bleed. That always will be the case, knowing these drugs can cause intracranial hemorrhage. But overall, this anticoagulation strategy is working quite well. Actually, I have one of the few of my patients who did not come to the cath lab, but with anticoagulation improved significantly in terms of their dead space, ventilation, breathing, and decreasing requirement of FiO2, so that did not require intubation, and a couple of them intubated, then were extubated. This is just being done for last 2 weeks. Before that, it was no uniform protocol. It's only for last 12 days or so, we have implemented this anticoagulation strategy.
Well, it's a phenomenon that we were not aware about it. It says, as you know more and more of those patients, you see those thrombotic events. And I think we have to adapt our treatments, even though the protocols has not been established yet by guidelines, et cetera, or by studies. Giora, anything that you want to share about this?
Yeah, I'm very concerned, and I'm dealing a lot with those thrombotic component of the COVID. And, others published a lot about the high rate of DVT and PE, and we see it in our COVID patients. But let's talk about the coronary patients. At least what my gut feeling, and this is, from a handful of cases that I cut with patient coming with a STEMI, but that's something that I believe that and hope that it will be investigated and published, is that what I see is patient that's much larger thrombus burden that I've seen in the past. So that has to be compared to other cases. There was one case that I did on heparin and needed 13 or 14,000 units of heparin. So we have from time to time those patients, but having also a COVID plus patient, it concerns me that they don't respond well to heparin. We have in our CCU, we have a few patients that had continued thrombotic events that were unrelated, despite the heparin use. And we actually the admitted patient that have a high D-dimer and high fibrinogen and have some thrombotic phenomena, we don't put them on heparin anymore. We put them on bivalirudin. Also, our nephrologists, they see the patient on heparin. They clot more the filters than they are used to. And they also change their anticoagulation patient that needs CVVH and dialysis. They give half a dose of bivalirudin, half a dose that we give during the dialysis sessions.
The question is how long you can keep the bivalirudin? I mean, this is not a drug that you can go home with.
No, I'm talking in-house or patient that, on vent or have a DVT and PE. And we have, unfortunately, many of those patients. Then when the patient go home or the protocol on the floor is very similar to what Sana is doing. It's giving a NOACs, half dose of apixaban, and even sending the patient home. Those patients that I told you about, patient we extubated, we're going to send them to an rehab. They cannot go home directly. They are very, very weak, and they will stay on oral anticoagulation.
So our last segment, I'd like to talk a little bit about how we go back. But before that, obviously, it is very pleasant to hear that the numbers of mortality and hospitalization in New York is coming down. And we watch every day the governor's speech, and we watch the numbers, and it's pleasant to see. It's a very slow reduction, but obviously if you want to see the reduction even more, we have to make sure that patients not gonna sit at home on their STEMIs and not gonna come. So how do we change the turn here so we can bring back patients into the lab, even during the transition time before the May 15, because how do we give them assurances that it's actually safer to come to the hospital rather than to stay at home? Samin?
Well, I can tell you this, it's a true, real issue. Yesterday, today, so many patients, I can believe, I never thought that I'll tell a patient, you need a procedure, you come, and he'll say no, he or she. And this is what's happening. And I take care of, just to give example, the gypsy community. I do about 50, 60 patients per month. Even those don't want to come. So just to say, at this time, I think what I learned in last 36, 48 hours is you probably had to wait till May 15th. If somebody will need it, of course, we are always accessible. We can, then we bring them. But in order to kind of roll out and get back to business will not happen before May 15th.
Do you consider to give PPE to the patients? I know one of the issues is the family cannot do visitation. I mean, they have to come by themselves. That's, I think, also one obstacle. And
that's a big, particularly for a few of the, the spouses who are patients 70s and 80s. They say, we never left our spouse alone in the hospital, so we are not bringing for that purpose. And many of them actually, the tower patients who have deferred for that particular reason, that unless you guarantee us they will be together in the room and a private room, would not come. So that has been, so yes, PPE has become routine. Even a few weeks ago, before all this, when coming up, patients who checked in, outpatient or inpatient, everybody got the glove. They already got used to get the cap and the mask. So that everybody getting surgical mask only. That is the mandatory, and more important that we have made it at the entry when patient comes in, that you do a temperature check. If patient has symptoms, and we have signed, same, I'm sure you have, everyone has that if you have those symptoms, please better you go home, and that procedure should be canceled or postponed.
Giora?
Yeah, I agree with Samin, and I want to highlight what Samin said earlier. I think the key will be to check the patients, and the patient know that we are being checked. So they are not in risk. I can tell you that not having able to have visitation for some of the elderly, it's difficult. Yesterday I had the pleasure to teach a patient how to do FaceTime. So with his family, and it was like kind of a new Zoom for patients as well. But we have to sit tight until May 15. I think we need to bite our lips and wait a little in order to go at the end faster and better to kind of normality.
So for New York, May 15 is the magic number right now, I assume, right?
But what about you? Are you going to start a little early, or is there a date set, deadline for in Washington, D.C. also? What's the story?
We don't have deadline, but our situation is not that bad as yours. I mean, right now in our hospital, which is a tertiary hospital, we have 180 patients. We didn't have to sacrifice a lot of our intensive care unit. And still, I see, I mean, we continue the TAVR program almost without interference. We respect the issues of not taking elective patients. But one of the issues that we try to do a lot of telemedicine, but the question with telemedicine, are we sending the patients the right message that they should stay away from the hospital rather than coming to the hospital? So again, we would follow whatever the governor of Maryland or the mayor of DC will tell us what to do. And again, we experiencing the same thing. What I have in my mind is like, okay, the day after, the day, whether it's May 15 in New York and maybe it's May 12 or who knows in DC, because some people says that our peak is going to be in June. But whatever is going to be the day, we have to be prepared and plan how do we bring the business back. And it's going to take a while, but we have to plan it. That's the question. So I wonder if you guys are brainstorming and have any thoughts, what do we need to do to bring the things back?
I think we actually already have prepared the document this last weekend, and starting with intake, rearranging the waiting area. So giving space that the two chairs you put upside down or so there is clear-cut gap. Second will be the same. You put a signs outside at 6 feet interval. So if patients are coming in, we know right now it's very scant, but they become 10, 15 or so later on. So they have, even by getting into the intake area, there is a space. Same way when they come out into the ambulatory area. So all those basically containment measures which are being taken and being advised as a good practice measure will be implemented. So that part already implemented, starting with the temperature on everyone. And once the patients have been done, and of course employees have been tested, once patient has been done, so idea would be that we do slow. That patient came in, and of course, if it's a COVID patient, that room to be cleaned before you put a second patient. But otherwise also, from not to burden the telemetry unit, we'll say that we will, each room will do, let's say we have 6 rooms, that only 3 or 4 cases for next 2 weeks. So there, and give it a gap in between. So everybody is prepared to manage them in a more comfortable and cool and calm atmosphere rather than rushing and exposing themselves. And we mandated the full PPE for the physicians. So that is, I mean, actually today's our virtual CCC live webcast. I first time wore the mask and cap. I'm not done for 129 episodes, and I did it today. Even there was no patient, but just to practice. And so, but I think this is a changing atmosphere. But yeah, PPE will be very important. It has to be available. And why we told the hospital, if those things are not available, we are not doing it. So they have provided that. I know many places there is a scanty, scant and not availability of the enough PPE. And in that case, I think physicians have the right to say that you need to provide this. We want to do really help the patient. But before we start, it's not that we are denying anybody, but before we start full service, that we need that. And same, that unit should be non-COVID. So there's
that's, I think, the key. The key
very
is
important. Once patient goes out, they will be going to the non-COVID unit.
Right. So, another thing that it might increase the trend is for same-day discharge, more radial procedures, because that's, those are the things that shorten the patient stay in the hospital, and it's a win-win.
Maybe one last question to you, Guy or Ryan, without mentioning names, but we do have also healthcare providers that get sick, and I think it goes almost with every hospital that take care of the patients. And how does it impact on the rest of the team when you work in a very close team and one of your peers or colleagues get it? I mean, how do you deal with that, and what's the impact on the rest of the team in terms of taking care of those patients?
I think it's highlight the unity and the collaboration, is that the team approach in a group. We had a couple of our physicians that were sick. Luckily, none of them from the interventionists was very sick. So they were lucky, and we all were lucky. We had a couple of nurses that were home and sick. But we all know about the other colleagues that were even sicker and in very bad situation, and even their life were at risk. Definitely, it makes us united. We cover for each other. We are, I think, get closer. We are friends, and we make any effort in order to give the best care for the patients that really need us. And we all know that with this disease, there is no 100% protection. And we are not 100% protected. Whatever we will do with the PPE, we don't have those overall cover that we have seen on TV maybe from China or other places. We don't have it. And we are all in risk, but we still have to protect each other, protect ourselves, and to cover each other.
Well, I cannot say more to thank you, first of all, for being on the front line. I mean, you've seen more than anybody else. It's a huge bravery, and you contributed a lot. So I think everybody owes you thanks, and you hear it from everyone. And also, it's important for you to stay safe and healthy. And I'd like to thank you for finding the time to be sharing some of your thoughts on very important and hot issues. And hope to see all of you again very, very shortly when all this will be over. Thank you very much.
Of course, and it will be over, and you stay safe and healthy. All right, Ron.
Thanks for the opportunity.